Warwick Forest. I'm loving this beautiful weather here by our scenic ponds. 4 laps around our ponds equals 1 mile, which makes an excellent opportunity for exercise here on our campus. Today, I'm introducing Dr. Mohan. After earning his medical degree from Wayne State University, Dr. Mohan completed an integrated vascular surgery residency at University of Massachusetts. He also holds a Master of Public Health from the University of Michigan and is a registered physician in vascular interpretation. Dr. Mohan enjoys the ability to tailor treatment for a multitude of problems through vascular surgery while developing long-term relationships with his patients. He sees each relationship as a partnership and thinks of his patients as his own family members, giving them his very best. He loves meeting new people and helping them achieve their cardiovascular health goals. Originally from the Midwest, Dr. Mohan loves Hampton Roads for its water, long spring and fall, and opportunities to spend time outdoors. He enjoys running, hiking, dancing, and watching movies. Without further ado, here's Dr. Mohan speaking on varicose veins and venous disorders.
Thank you so much for joining me today. It's my pleasure to speak a little bit about vascular disease, specifically focusing on veins and venous disease. Again, thank you for that introduction. My name is Satish Mohan. I'm a board-certified vascular surgeon working here at Riverside, and been here about 2 years, and we're having a great time. So vascular disease is a very broad topic, and today I'd like to spend some time focusing on veins. And this is a common term that we throw around, blood flowing in our veins, etc. But I'd like to make that a little bit more clear for you today. So to start out with, let's go over a little bit of anatomy. So you can think of arteries and veins as the plumbing system of the body. The heart is the pump, and oxygen-filled blood travels through the arteries to the rest of the body, to the organs and our limbs. The tissues take up that oxygen, and then oxygen-depleted blood is then transferred back to the heart via the veins. So you can think of the arterial and venous system as a 2-lane highway with flow going in opposite directions. So in these images here, you can see that the red denotes the arteries and the blue denotes the veins. And so blood is coming down the arteries and then going back up via the veins. I'd like to focus on the veins of the leg specifically because this is typically where we see most issues with patients. In the legs, there are 2 systems of veins, the deep veins and the superficial veins. The deep veins pictured here do the majority of the work in bringing blood back up to the heart. They drain all the deep tissues, the muscles, and then as they start out smaller, and then as you go up the leg, they become larger in diameter. The superficial veins, on the other hand, kind of collect excess fluid in the subcutaneous tissue and the dermis, and then collect it and eventually join the deep system up near the groin. And the superficial veins are important to know because these are often the source of pain and other varicose vein issues. There are another system of veins connecting between the superficial and deep veins all along the leg called perforator veins. These are important because they can play a role in varicose veins and may have a role in how the blood flows, whether it's in the correct direction or incorrect direction. We'll talk more about valves in a minute, but I just wanted to introduce them to you now. So arteries are muscular, meaning as the heart pumps, blood is passed through the arteries and there's an elastic component that propels the blood through the arteries. However, in veins, they're much more thin-walled and blood is actually pushed up via muscles and our positioning. So these valves act as one-way valves to prevent blood that's pushed up from coming back down. However, these can be a source of problem as we will discuss further. Essentially, that's basically it. It's a plumbing system where there are a series of veins that all collect and have one-way valves within them to help blood get transported back to the heart. Let's look a little bit deeper at the physiology of veins. So veins have two main functions. One, like we discussed, they return blood back to the heart. Now they also act as a capacitance system. They help maintain the amount of blood volume that we have by either storing or releasing more blood into the overall circulation. And so they can either expand when there's increased volume of fluid and blood in the body. So, for example, when someone may have congestive heart failure, their veins may expand, especially in the belly, and this allows them to accommodate the excess fluid in their body. In other situations, when someone's really dehydrated, the veins will contract to allow for more of the existing blood to get to the tissues. So how does blood actually flow in the veins? So when we're supine or laying down, there's no effect of gravity. So the flow of blood in the veins is actually dictated by a difference in pressures. So the pressure near the heart, where the veins are heading to, is actually lower than the pressure that's seen in the tissues or down in the feet. And so blood preferentially flows from the higher pressure system to the lower pressure system. So as we see here, in the venous end of the capillary bed or in our tissues, it's about 12 to 18 millimeters of mercury. However, it's only about 4 to 7 millimeters of mercury in the right atrium in the heart. And so blood flows from the feet and the tissues to the heart. Now, what happens if we stand upright? In this situation, there's a huge effect of gravity. So blood is actually being pulled down by gravity. And if we actually look at the pressures here, in someone that's 160 centimeters tall, the pressure is 123 millimeters of mercury down at the feet compared to the heart. And so that's a lot of pressure to overcome to get the blood back to the heart. How do we do this? There's an ingenious system where as we walk, the muscles in our calves, especially calves, thighs, and feet, compress the veins around them, which then pushes the blood up. And then these one-way valves prevent that blood from coming back down. Eventually, it moves up in segments back up to the heart. So like I mentioned, these muscle pumps are very important. They're located in the thighs, the calf, the bottom of our feet. The calf muscles are the most important in this process. There are veins within the muscle itself and around the muscle that all get compressed when we walk. This is especially important later on when we'll talk about situations where people get varicose veins when they stand for long periods of time or sit for long periods of time, and because of their profession, for example. And so since the muscle is not working very often, the blood just pools down in our legs. That can lead to swelling and varicose veins, etc. As you can see here, that contraction itself is a very strong mechanism and generates up to 200 millimeters of mercury of pressure. So that's enough to overcome that pressure exerted by gravity. And this is a graph kind of showing how much blood volume and pressure changes with exercise of the calves. So we can see here in the top graph that the amount of volume change decreases when we're exercising, and then when we stop exercise, the volume goes back up. So that tells you that the volume decreases with exercise. And if you look at the pressure, it significantly drops very quickly when we start to exercise because the veins are being pushed on very significantly, and that propels the blood back to the heart. Again, when the exercise stops, you can see that the pressure goes up again because blood is again pooling there. This also increases perfusion across the capillary bed. And so when we exercise, blood is pulled through the capillaries and from the tissues into the venous system. And so that also helps reduce the amount of swelling and extravascular fluid in the tissues. So I mentioned capacitance earlier. So veins act as a reservoir for blood when there's either too much blood or too little blood. And so our body is able to accommodate for these changes and try to maintain a relatively stable blood volume that's circulated with each heartbeat. So veins can have up to 60 to 80% of circulating blood stored in the venous capacitance system. So as you see here, as the increase in volume occurs, you can see that the pressure across the wall of the vein increases. And this is important because as pressure increases, that also increases venous hypertension. And so veins can get engorged for a number of reasons. One, it could be from increased volume, but it could also be from some kind of obstruction down the road for where blood is trying to flow. And so this increases the back pressure and increases the transmural pressure, which can again lead to problems that we'll talk about. How is this regulated? There's both active and passive mechanisms. So passive distension or recoil. So veins just passively fill up with blood and accommodate more blood. But there's also input from our autonomic system where there's some small muscle cells within the wall of the venous system that allows for some contraction. And this also plays a role in how much blood volume is stored in the veins. All right, so we've talked a little bit about the anatomy and the physiology of veins and how they work. So let's get to the meat of the talk here. So what can go wrong with veins? There's really two main things that can go wrong. One is you can develop clots in the veins, both clots in the superficial system and the deep system. You can also have abnormal flow going in the wrong direction, or slow flow, etc. And both of these are linked and can cause various types of problems. So this is kind of a kind of a common patient we may see in the vascular clinic. So, and the picture on your left is someone with a swollen right leg compared to the left leg. And this is likely someone who has a deep vein thrombosis or a DVT, a clot in one of their deep veins that's led to blood being backed up and swell and cause swelling of the right leg. The patient on the right has varicose veins, and you can see that those veins are popping out, and there's some skin changes on the calf there. It's becoming dark, and they may have pain, aching, and bursting type sensations when they walk. All of these things because of blood flowing in the wrong direction. So let's start out with the clotting side of this. What causes blood clots to form? This is a major problem in the healthcare system and something that we see almost on a daily basis, mainly because there are many reasons to get blood clots. As you can read here, there's over 900,000 cases of DVT and PE, which is pulmonary embolism or blood clot breaking off from the leg going to the lungs per year. And about a third of those can lead to death. So it can be a fairly morbid and high mortality problem. There are both hereditary and acquired reasons for developing blood clots. There are several genetic predispositions to forming clot. And patients with one of these disorders may have higher propensity to develop clot. And so usually this is identified after they've had recurrent episodes of DVT, and they end up being on blood thinners for life. But aside from that, there are also many acquired causes, everything from recent surgery, medications like oral contraceptives or hormone replacement therapy, pregnancy, recent travel, falls and other traumas, various diseases that increase the risk of blood clots, and even just being immobile for long periods of time. And so that one of the reasons we ask patients to be active and walk on a regular basis. Avoid sitting for more than an hour or two at a time. So as if you can imagine having a predisposition with a genetic problem and adding on an acquired issue like one of these things listed here makes patients at high risk for blood clots. This is a little bit of a busy slide, but basically this is showing how there are multiple hypercoagulable or high risk for clotting conditions that can be inherited or acquired, and adding on inflammation and infection on top of that leads to some sort of vein injury. This leads to clot formation, which can either break off and go to the lungs, or it may resolve on its own and be fine, or it may not resolve and cause the valves in the veins to work improperly, leading to varicose veins and skin changes and swelling, inflammation, etc. So the best option here is to prevent this from occurring. So there are three main components to what may form a blood clot. So first is stasis, or blood not flowing. For example, someone who's been immobilized. Take someone who's had some kind of leg fracture. They're in a cast. They haven't been moving around much at all. And then all of a sudden they get swelling of one or both legs. And this is because their blood's not flowing, they're not walking, those calf muscles we talked about are not pumping, and it leads to stasis. Endothelial injury. So the inner lining of the veins is called the endothelium. And if there's some kind of injury to that, it can predispose to factors or molecules on the lining that increase the clotting risk. So things like having catheters in the veins, smoking, various things that damage that lining can cause clot form. Hypercoagulable states, or things we talked about, genetic predispositions or other situations where someone may be at an overall condition of increased clot formation. For example, falls, trauma, pregnancy, active cancer or malignancy, contraceptive use, and the genetic predisposition we talked about. So let's focus on deep vein thrombosis. So deep vein thrombosis, or DVT, is essentially a blood clot in the deep veins, not the superficial veins. That's why I wanted to kind of delineate between the two, because the treatment for both of them and the prognosis for both of them is very different. So a DVT, or blood clot in the deep veins, can cause pain, a lot of swelling, and can do a number of things. A small piece can break off and go to the lungs, because as we looked on the image, all the veins come together, they join with the inferior vena cava in the belly, and then eventually go to the heart on the right side. And then from there, it's then pumped to the lungs, where blood is then filled again with oxygen. So in that process, the clot travels from the veins to the right side of the heart, and then to the lungs, where it gets lodged and can cause lack of blood flow to the lung tissue itself. It can cause lung parenchyma, or lung tissue, to die. It can cause drop in oxygenation. It can be very life-threatening. Typically, if this does happen, they're smaller clots, and patients notice kind of a change or chest heaviness or shortness of breath that brings them to seek some medical attention. Now, the other thing that can happen is that the clot just stays there. And if you look at this image here, you can see valves there, the clot kind of adherent to the valve, and that prevents the valve from working properly. So blood goes up, but this valve is not working properly, so the blood comes right back down. And that can lead to chronic swelling and inflammation and skin changes and even ulcers of the legs, which is called post-thrombotic syndrome. This is a syndrome that occurs usually 5 to 10 years after initial event of significant blood clot, but can be very debilitating and impede quality of life. How do we diagnose DVT? Like we talked about, patients usually present with leg pain or swelling. They may have some change in the coloration of their skin. In very severe cases, they can be red, purple, even white. So when we see this, we do get concerned. We diagnose them typically with an ultrasound. We're able to look at the veins themselves to see if there's the veins kind of distended, if there's clot within the vein, whether there's flow going through the vein or not. And we're able to see how high up that clot extends, whether it's just in the calf or extends up to the thigh or even into the pelvis area. Blood tests include something called a D-dimer test, which is a test looking for fibrin degradation products, which is non-specific, but tells us that there's some kind of inflammation or something going on in the body. So this picture here shows someone with phlegmasia, and this is a clear difference between the two legs. The left leg is filled with DVT, and so blood is not able to return back to the heart, so the leg gets engorged, and there's lack of perfusion or oxygen delivery to the tissues, so everything becomes very engorged and inflamed, and if left alone, eventually you'll have loss of muscle or nerves and may even have to lose the leg. So this image is demonstrating what DVT would look like under ultrasound. So this large circle in the middle typically would have a color inside it showing that blood's flowing. It would be compressible when we pushed on it, but in this situation, we're not able to see any of those things. So this is clearly an acute DVT. I'll just take an aside here. It's also important to understand the difference between an acute DVT and a chronic DVT. An acute DVT is more likely to embolize and cause issues, and that's why we put patients on blood thinners. Chronic DVT, on the other hand, is essentially just scar from the body healing an acute DVT. And notice or findings of a chronic DVT isn't any major cause for alarm, except to note that the patient likely had a DVT at some point prior to that. All right, so we talked about pulmonary embolism. It could be life-threatening, high mortality if not treated. The majority of them are due to blood clots developing in the legs and then breaking off and traveling to the lungs. We talked about post-thrombotic syndrome. 5 to 10 years, higher risk of all of these things: swelling, hardening of the skin, repeated infections of the skin, even ulcers that may develop. And to prevent this, we'll talk about wearing compression stockings. The main treatment of deep vein thrombosis or acute deep vein thrombosis is anticoagulation or blood thinners. This helps stabilize the existing clot and prevents it from either propagating and even breaking off and embolizing or going to the lungs. The first thing we try to figure out when someone comes to us with a DVT is what provoked it, meaning is there some etiology that we can explain as to why this occurred. And typically this is a short-term problem. Someone just had surgery or they just went on a long car trip, something like that, and this isn't something they're going to be doing every day. And so we put them on a limited time frame of blood thinners, usually 3 to 6 months. And then once that initial cause of the DVT is taken away, they no longer have that propensity for clotting. However, if there was no cause that we can identify and happened just on its own, then we're more suspicious for an underlying genetic cause where we may have to treat them for a longer period of time or even indefinitely and lifelong. They're both pill and IV forms of anticoagulation. You may have heard of Coumadin or warfarin, which is the oldest type that we have and we still use, but newer medications called Xarelto, Eliquis, Pradaxa, these are also on the market and also ones that we use on a regular basis. And we tailor them according to the patient and according to the underlying problem. Elevation and compression is essential. Elevation allows the swelling and fluid to be pulled back into the heart because gravity is acting on it. And compression, the same reason. It helps reduce the swelling in the tissue, and that in turn reduces the inflammation in the tissue and prevents long-term effects like post-traumatic syndrome. In situations of phlegmasia, like that patient we saw a few slides ago where the entire leg was purple, someone that may have DVT extending up into their pelvis, we talk about doing an invasive therapy to actually break down that clot or suction it out. Usually we take the patient to the cath lab, we go into the vein with a needle and catheters, and we can either use clot busting medications to break up the clot itself, or we can use a suction device to actually suction out the clot. And we look for what may have led to, if there's any anatomic issues that may have led to this DVT. The goal here is to reduce the long-term effects of swelling, skin compromise, and the post-traumatic syndrome. On occasion, you may have heard of an inferior vena cava filter or IVC filter. This is often a talked about thing in the media or lawyer commercials, but I think it's important to understand why and when it's appropriate for use. So on occasion, someone is found, for example, they had a recent stroke and they've also developed a blood clot in the leg. In that situation, they may not be appropriate for a blood thinner, because if they have a blood thinner after a recent stroke, they may develop bleed in the brain. So in those situations, we put a special device in the vein, large vein in the belly, called the inferior vena cava. And this, it looks like just like this. There were several different types. It's like an inverted umbrella, and we deploy it just below the kidney veins in the belly. And so if any clot breaks off from the leg and travels, it gets caught in this filter without going up to the heart and eventually to the lungs. And the goal is, this is in place only for the time that it's required. So let's say this patient with a stroke ultimately recovered, and 3 months down the line, 4 months down the line, they've gone to rehab, they're back to walking, and they're feeling better. We would recommend that we take the patient back. We actually go in from the vein here in the neck to try and snare this. First, we check to make sure there's no clot inside it. Then we snare it and take out the filter that way. And so it's only supposed to be there for a temporary period of time in most situations. In some situations, patients may never be a candidate for blood thinners, or they still have ongoing issues for blood clots. And so in certain situations, they may need to have the filter left in lifelong. It can have its own complications and may actually be a nidus for clot formation, and can actually cause clot to develop in patients who otherwise wouldn't have. So that's why we try to take it out when it's no longer needed. All right, so we've gone from the DVT, we've talked about how it presented, how to treat it, what to look for. Let's kind of change direction a little bit and talk about varicose veins. So chronic venous insufficiency is essentially referring to the fact that these one-way valves inside these veins are not working properly. And so blood is pumped up and then comes right back down, and so hangs out in these veins. This leads to swelling. It leads to kind of this kind of tortuous curling of the veins that we term as varicose veins. It can present in multiple ways. It can be just some little spider veins that you see on our leg that most of us get with age, and most of the time it doesn't bother you. It's just something we see, and it's nothing to worry about. Nothing really that'll no damage that it's doing. Other times it can be more obvious. The veins are popping out of our legs, and when we stand for long periods of time, the area is achy, it itches, it hurts, and you may even have episodes where there's little clots that form inside these varicose veins and can be very tender to touch or even to walk. In very severe situations, this constant flow of blood in the wrong direction leads to a lot of venous hypertension, we call it, and inflammation right around this area, just above the inside ankle area. That leads to skin being very inflamed and even leads to ulcers. And so we try to look for these things that are developing and treat these veins if they need to be. Now we categorize chronic venous insufficiency in a scale here. So we'll focus on this clinical term here. C0 is essentially no clinical signs. C1 refers to telangiectasias or reticular veins. This is essentially like this spider vein, and slightly larger than spider vein veins you can see in this image here. C2 refers to varicose veins that are clearly seen and may be symptomatic. C3 refers to swelling associated with varicose veins. C4 is getting to the point where we actually see skin changes. There's a darkening of the skin, and the skin may become very tight and very shiny, and that's kind of like this presentation. C5 is a healed ulcer, and C6 is an active ulcer because of venous insufficiency, and it's typically seen in this location, just above the ankle area. So we talked a little bit about why this occurs. Most commonly, it's because of valve failure. Either the valve itself is not working properly, or secondarily, because there was a blood clot or something previously that prevent the valves from working properly. This leads to increased venous pressure, venous distension. The blood products actually leak into the tissue. So there's iron products within blood cells, and so that hemosiderin, we call it, leaks out into the tissue and actually stains the skin. And that's why we see a darkening of the skin in those areas. Another reason that could be obstruction. So like I mentioned before, there may be a clot downstream that's preventing the blood from flowing. And so blood is chronically there's a back pressure there, and the veins are pulled apart because of the increased flow, and those valves are not able to meet, and so blood is still flowing in the wrong direction. This can be congenital, such as a condition called Klippel-Trenaunay syndrome, or acquired, which is also congenital, but May-Thurner syndrome. We'll talk a little bit more about that. When patients have both issues, when the valves are not working properly because of an innate issue and there's some kind of obstruction, those patients tend to have the worst symptoms and ultimately have ulcers, etc. We talked a little bit about this, but just to go over it real quickly, the blood is flowing in the wrong direction because these valves are not working properly. The veins engorge. There's blood cells and inflammatory cells that leak out of the veins into the tissue that increases inflammation in that area and causes breakdown of the skin and undermines the integrity of the skin, which then ultimately leads to an ulcer formation here. I mentioned May-Thurner syndrome. You may have heard this term before. This is an anatomic issue where the iliac vein, the left common iliac vein, which is the large vein in our pelvis, is compressed by the right common iliac artery. And so vein is compressed there, and so when blood tries to flow back this way, there's a compression here, and there's a back pressure down that left leg. So a lot of times we see this more commonly in females, usually in their 40s to 50s, 60s. And if they have unilateral swelling like this and blood clots, either once or multiple times, we do assess for this situation where the vein is compressed proximally. In those situations, we actually go in and put a stent across this area so that the vein can be kept expanded and no longer compressed. So we may have patients on a broad spectrum of presentation with chronic venous insufficiency or varicose veins. How do we treat them? The first step is non-operative management. So all of my patients that come in with this problem, I tell them the most important thing is regular walking and exercise to activate those calf pumps to push that blood and fluid out of the leg. Compression, so this is compression stockings. They should be worn every day when getting dressed in the morning. until we go to bed at night, because that's the time we're on our feet and gravity is actually pulling down on the blood. Elevation, anytime we sit or we sleep, we want to keep our legs elevated above the level of our heart to allow us to pull that blood out of our legs. And of course, skin care. We don't want to let the skin get too dried out and predispose it to getting wounds and ulcers. Now, a lot of times we do this, but patients still have a lot of symptoms. Um, we first document by ultrasound that their valves are not working properly, and then we can talk about invasive therapies. Really quick on compression stockings, there are a variety of options. They go anywhere from the calf to above the knee to the thigh, all the way up to a pantyhose style. There are elastic ones, there are zipper up ones, there are ones that are open toes, there are Velcro compression wraps that are easier to put on sometimes than the really tight compression wraps. But it's quite challenging to wear sometimes, but it is really the most important thing in preventing things from getting worse. So in those situations where the non-operative treatments are not enough, we talk about surgical options. So now there's open surgery and minimally invasive techniques that we can use. Open surgery, which has kind of been done historically, and we still use from time to time in the appropriate situation. We actually go into the vein, go into the leg here, make a small incision in the groin, excuse me, small incision in the groin. We tie off and separate the vein here. And we actually pull out this vein and take it out of the leg. We can also make small little incisions along these varicose veins and then pull them out. And we'll see pictures of that later. We can do this for the superficial veins. Now, obviously, like I mentioned to you before, the deep veins do the majority of the work in bringing blood back to the heart. And so we can't do this for the deep veins, but we can do this for the superficial veins. And we can take them out, and there's no major issue because blood is already flowing in the wrong direction in these veins anyway, and so they're not really contributing to getting blood back to your heart. The minimally invasive options include an ablation. So we actually access the vein kind of in this area, just the top part of your calf. We go into the vein, we numb up the skin, go into the vein with a needle, and put in a catheter, and we actually either burn or glue the vein shut. And so this prevents blood from going down this vein and the venous hypertension, etc., that comes along with it. So there's ablation, which is either done with radio frequency or sound waves, or with a laser to shut it down. We can use a surgical glue. And in certain situations, we can also use sclerosing agents, chemical agents that actually cause irritation of the lining of the inside of the vein and cause clot formation and cause it to shut down. That's called sclerotherapy. So this image here just shows how that catheter heats up the inside of the vein, then the vein is shut down because of that damage that it does. So this is an image of someone that's had stab phlebectomy. So you saw the before picture, and they were taken to the operating room or in the office, and the small little incisions made along the veins, and the varicose veins were taken out. And as you can see, that there's an excellent result. Ablation, like I mentioned. So you can see how before there were all these varicosities coming off of the main vein here called the great saphenous vein. And after treatment, you can see that all of that has dissipated and those legs looking much better. Sclerotherapy is done typically for smaller veins. These can also be quite painful or even done for cosmetic reasons, but we can inject these small little veins and cause those veins to shut down. And so you can see that we get rid of all of these arrays of veins coming off the underlying vein there. All right, so are we at risk? I think it's important to understand both your personal history, what are your comorbidities, have you had blood clots previously, do you have a job or condition that causes you to sit or stand for long periods of time? These are all things to consider for your vein health. Also important to talk to your family. If your mom or your dad had varicose veins or your siblings had varicose veins, you may be at higher risk for varicose veins, if not now, at some point in your life. So just to get a sense of where you stand. How can we prevent the disorders related to the veins itself? Again, avoid long periods of standing or sitting. Um, just try to get up and walk every hour or two. And if you're going for long car trips or long plane rides, try to wear compression stockings and do get up whenever possible. The compression stockings will be key. I try to wear compression stockings because I'm in the OR standing or the cath lab standing all day. So I wear them just to prevent any issues down the line. Now, obviously, skincare, ensure that your skin isn't getting too dried out. There isn't anything else that looks concerning. Um, and lastly, if you do have vein issues, please come see me or any vascular surgeon, and we can talk to you about your symptoms and your condition and see if anything else needs to be done. So thank you again for attending, and I can certainly answer any questions or thoughts. Let's see, when leg veins are used for heart bypass surgery, does the body then build new veins in the legs? No, the body doesn't build new veins, but like I mentioned, the veins that are used for either bypass of the heart or bypass for arterial issues are the superficial veins. And so the deep veins kind of pick up the slack and take blood back to the heart that way. Can varicose veins in the legs cause or contribute to high blood pressure? Usually no, they're not directly related. High blood pressure is related to either a heart issue or hardening of the arteries itself that increases the blood pressure, but not directly related to varicose veins. Some of the companies that provide you with stents. There are various venous stents on the market right now. Boston Scientific makes a stent. Cook Medical makes a stent. There are the wall stents that have been used previously as well. These are the most common ones that we use. Venous stents are relatively new to the market. Previously, we were using wall stents that were originally designed for kind of the GI tract. How to tell if compression stockings are too tight? Well, unfortunately, if they're not tight enough, compression stockings aren't really doing much for you. So we want them to be tight. Now, obviously, if you can't walk or it hurts a lot or it's cutting off circulation somehow, you may have to reduce the amount of compressions giving you. But if it's just some discomfort and it may just take time to get you used to, I would try to give it a shot because the tighter it is, the better compression and reduction in swelling that we can accomplish with that. How long can it take for a clot to form? It's hard to say exactly, but clot can form in minutes, depending on what the etiology is. Now, someone who's had some kind of underlying injury to the vein may take a couple of days, perhaps, for the swelling to occur. A lot of times, patients may go on a long car ride, and the next day or two, they notice that suddenly their leg is swollen. So it can be anywhere from a couple of hours to a couple of days. What is the relationship of vasculitis and peripheral neuropathy? That's kind of a talk on its own, but basically peripheral neuropathy is a result of the little nerve endings in your feet usually that are not working properly, and so they are firing incorrectly, so that leads to sensations of numbness or burning that can be very bothersome. Now we need to kind of differentiate this from other causes of pain, from veins, for example, which is usually kind of the inside of the leg and not in the bottom of the feet or the toes, where peripheral neuropathy is usually affected by. Vasculitis is quite variable. It's basically inflammation of the blood vessels. It can affect anywhere from large blood vessels all the way to small blood vessels. Um, I don't know if there's a direct relationship between vasculitis and peripheral neuropathy, because one is affecting the blood vessels, the other is affecting the nerves, but they may be situations where they're both affected by a common inflammation or um, uncontrolled diabetes, that kind of thing. What causes increased bruising and sometimes bleeding on lower arms when we run into doors, etc., as we age? It could be a number of things. Number one, when we age, the layer of the skin called the dermis actually thins out. And so you may have noticed our parents or grandparents, their arms, their skin seems almost papery, very thin. It's because that dermis layer actually thins as we get older. And so as we get older, when that thins and we do bump ourselves, there's more tissue there. There's more area for blood to kind of develop. So basically, we're developing a bruise more easily. If we were younger and that skin was, the dermal layer was more thick, you may have a little bruise, but it won't be nearly as big because there's no room for it because the dermis is nice and thick. So that's why we tend to see that as we age. Now, patients who are also on blood thinners or antiplatelet therapies also are at higher risk for bleeding because it thins out the blood. Will varicose veins contribute to leg spasms? And this is actually a common thing that we get asked about. So a lot of patients talk about calf kind of Charlie horse or pain at nighttime. They have to get up and shake it out, that kind of thing. And there may be a little bit of connection there, but it's hard to pinpoint directly what may be causing that. Typically, if it is very classic venous insufficiency type symptoms, it's pain kind of in the inside of the leg there that worsens with standing, kind of gets better in the mornings after being in bed all night. But on occasion, I have seen patients that have said that their spasms have gotten better after we treated their varicose veins. Is the treatment the same for a DVT even if no cause is determined? Yes. So as long as someone has an acute DVT, we start them on blood thinners as long as they are able to take it. Now, in situations like I mentioned where they can't get a blood thinner, we may need to consider an IVC filter. The difference between a situation where the cause is determined, where the cause is not determined, is the length of treatment. If there is a cause that we can identify, we typically limit it to 3 to 6 months of blood thinners. If there is no cause that we can identify, we may have to talk to them about risks of either longer anticoagulation or even indefinite anticoagulation lifelong. And that's something we have to talk to the patient about, maybe assess for genetic predisposition and kind of weigh the risks and benefits of lifelong anticoagulation. Are there foods or supplements that can protect or even improve the dermis? Generally, your standard daily multivitamin has everything we need. Your standard vitamin A, vitamin E, all support the skin. And I don't think there's any way to artificially prevent the natural aging that we incur, but we can prevent additional damage to it by wearing sunscreen when we're exposed to the sun, and making sure we have a nutritious diet. Alrighty, I think I got to all of them. Is there anything else that was not clear or anyone would like to see or hear about again? Surgical glue. All right. This is basically a a glue. It's called VenaSeal. It's a compound that basically uh, forces the two walls of the vein to shut down. And so we kind of pick the patients that we use the glue for, because if patients have some prior allergies to adhesives or a lot of allergies in general, they can have reactions to this, because once the glue is in there, it's going to be in there for life. So we try to make sure we pick the appropriate patients when we use that glue. Difference between disease of the arteries and veins. Um, there are very kind of different etiologies for diseases of the arteries and the veins. Like we mentioned, the veins are basically either blood clots or incorrect flow of the blood. Arteries, we typically see diseases as a result of atherosclerosis, which is a buildup of cholesterol and fat cells in the lining of the blood vessel, which can lead to narrowing, aneurysms, that sort of thing. So very quite different etiologies, and usually arterial pathologies tend to be in more serious diseases in patients that are generally more sick. Something called shortness of breath. Yeah, so if someone has a PE, or pulmonary embolism, so someone gets a blood clot in the leg, which then breaks off from the leg, travels through the veins up to the heart, and then from the heart to the lungs and gets lodged in the lungs, that can cause shortness of breath. But typically that's a sudden thing. It's not something that's developed for months and months. It's a sudden onset thing, and the patient's otherwise been fine prior to that. That's when we get suspicious for a PE. The choices to be made: which is best for the aging body, walking or swimming? I think whichever one suits you better. I think both are excellent. Water aerobics has been an excellent form of exercise that's been less pressure on the joints. Patients that have a lot of arthritic issues tend to have a lot of benefit from that. But if patients can walk, that's what I recommend for all of my patients. Just 40 minutes of walking a day, that would be the goal. But even if you can start with 10 minutes in the morning, 10 minutes in the evening, and slowly build that up, I think there's a lot of benefit to be had. The healthiest 80 and 90-year-olds I see in my clinic are those that have kept up with their exercise. And so I would call exercise the closest thing to a panacea that we have. All right. Well, thank you, everyone. And please reach out to me if there's any other questions. Thank you.